And now Sandy will take a look at patients with relapsed myeloma.
Thank you, Paige. So we're going to shift gears now and talk more about the relapsed and/or refractory population in multiple myeloma. So this is one of my favorite slides. I think it tells a very important story about this disease in particular, and what it shows you is the disease trajectory over time. And so Joseph and Beth talked to you about the smoldering patients and MGUS patients, and then when they developed the CRAB criteria and developed active disease, that was the point at which we needed to take action and get them on effective therapies. And our goal at that point is early depth of response. We want to see the myeloma protein be reduced very quickly, and then we want to keep it there for as long as possible. We know that early depth of response, a sustained response, and initial therapy correlates to improved overall survival. Unfortunately, with multiple myeloma, relapse and multiple relapses for most patients are inevitable. And each time the disease relapses, we have the problem of less of a depth of response and usually a much shorter response. And so I want you to keep those concepts in mind as we go through some of the rationale for continued therapies in particular. This is the slide that Paige showed you, and what we're going to focus really on are the two more recent developments, newly approved compounds being carfilzomib and pomalidomide, which were really approved with the relapsed refractory population in mind. So let me introduce you to Indira. She was diagnosed 6 years ago with IgG-kappa myeloma. She was 61 at the time. She's currently 67. She was treated with bortezomib and dex for 4 cycles, followed by an autologous stem cell transplant, very typical scenario. She did not have maintenance therapy at that time and remained in remission for 6 years, so a very good, durable remission. However, in routine follow-up, we continue to follow patients on a regular basis. We began to see sequential increases in serum-free light chains and her M protein. So very important as we're monitoring patients over time, we keep an eye on those numbers. We start to see them creeping up a little bit. We may bring their visits a little bit closer together. And if you see them doubling or tripling over 3 sequential checks, for instance, there's something real going on. She also developed some symptoms of fatigue, and we started to see changes in her other labs, specifically creatinine and beta-2. And so we're worried about relapse, and we're going to do a standard relapse workup, which looks very much the same as an initial workup for these patients. So full skeletal survey. We now see some new lytic lesions in Indira. We're also going to do a bone marrow biopsy and aspirate, send it for cytogenetics. That's essentially the tissue biopsy for this disease. We see an elevated plasma cell count, cytogenetics including 17p. 17p is not a good thing to have. It's correlated to the p53 oncogene, not good in any disease, including myeloma. We also going to do the myeloma profile. So we're categorizing the heavy chain and the light chain, in this case IgG and kappa, and you can see that both of those numbers are elevated. And your M protein, which normally should be 0, is elevated as well. CBC with chemistry, not a lot going on here, except that we do see the creatinine of 2.3, which you probably are going to believe has something to do with this excess myeloma protein, which is plugging up the kidneys, basically.
So earlier it was discussed this idea of minimal residual disease, the idea that there's an abnormal clone or an abnormal protein or abnormal something living in the bone marrow that will eventually reemerge. And the importance of this slide is showing you that multiple myeloma is a clonal disease, a clone of one normal protein and immunoglobulin, and that clone, though, will change over time. So when Indira is diagnosed, we had that first abnormal protein and we treated that, we got rid of it. And I think of it as bullies in the playground. So you have that one dominant bully or dominant clone and you get rid of it, that's your protein. Now the second time that clone or that bully reemerges, it might be harder to bait down. And so you can see on this slide the pie charts, they kept adding in different therapies, and unfortunately, as was in this study, the patient had developed plasma cell leukemia. So those clones changed over time, and we call that clonal evolution. And that argues for keeping the individual on therapy until progressive disease or unacceptable toxicity. Now, Indira underwent a transplant, and she did great. She had a nice long remission from the transplant, did well with it, and there are research studies that suggest that it is reasonable to have another transplant. A second transplant is typically performed in a shorter period of time, but this study illustrates that maybe if they had a meaningful duration of response, that can be replicated by a second transplant. So this option should be discussed with her. We should have that discussion of all the options, and then maybe that's something she would consider.
So when we look at the options, so she basically has relapsed multiple myeloma with clonal evolution, so she has this new cytogenetic finding which is unfavorable. You're going to go back and say, what are my options? And it's a good problem to have, but it's also a challenge in that there are many possible treatment regimens that could be considered at this time. She's had such a long treatment-free interval. So the tricky part here is there isn't one right answer. There's a lot of variability across the country and throughout the world in what regimen is favored depending on where you are. And that can be challenging for us to explain to patients why we prefer one regimen over the other, because there is no consensus really. So one of the things, or several of the things we're going to do, we're going to look at what did we already do, how did it work, how long did it work, were there any adverse events, and are any of those still present, so residual adverse events that might make a difference in the next thing that you choose. And then certainly and always we need patient preference. So we're going to tell the people what we know, what we understand, what the science says, and then they really get to choose is the bottom line. So we're going to look at all of this information, and for Indira, she said, thank you, no, I don't really want to have a second transplant. That's okay, right? They choose. And so instead, we chose the 3-drug regimen. We heard about triplets and doublets, bortezomib, lenalidomide, dexamethasone. And because of the skeletal findings, we're going to start her on a bisphosphonate, and in this case, it's pamidronate, excuse me. So after 4 cycles, she had a very good partial remission. 4 additional cycles, she achieved a CR. That's a great outcome. So then we lightened up a little bit, kept her on therapy, lenalidomide maintenance, but continued the bisphosphonate support. Now let's talk a little bit about Indira and her family situation, which probably has a lot to do with her personal choice and perhaps not wanting to consider a second transplant. She's married, her husband is 69, a retired engineer, probably just retired. They probably looked forward to spending time together. They have 3 grown children that live nearby, less than an hour away. A lot of that is what you want to be doing. Probably also a few cruises and other things mixed in there, right? When you get there, you're always, doubling as a travel agent for our patients, getting them on the next cruise. Patient concerns, she's certainly worried about her prognosis. Now, she may think, you know what, I'm going to do just as well as the last time, but we're going to have to talk to her about her high-risk features. But she really wants to spend time with her family, and she's worried about side effects. So the family part is so critical here, and we did include in our most recent supplement, the CJON supplement, which you have access to on bone marrow transplantation, is the issue of caregivers. And for a transplant, caregivers are prerequisite to even being considered for transplant. You have to have one, they have to be reliable. Some people have several and in rotation. What we don't always think about is what does this have, how does this affect the caregiver specifically? We need to take care of them as much as we take care of the patient. So there are many different elements, physical, social, certainly emotional, financial, just logistic concerns that caregivers have that create a lot of caregiver stress. We ask them to incorporate a lot of information, some of it very complex, very quickly. And if you come to the clinic and with a visit with that patient, dubs you're it, tag you're it, you're a caregiver, right? You come, you're a caregiver. We just assume that you're part of the solution. And you may not be comfortable with that, and you may have no skills whatsoever, but that's just assumed. So we need to really get a little bit more formal in assessing these caregivers as much as we assess those patients. I always use the analogy, when you get married, I'm about to celebrate my 31st wedding anniversary, and I remember, signing that thing, the marriage certificate, but I didn't see the fine print where it says, including but not limited to, right? IV care, dressing changes, flushing catheters, right? So we just sign you up. You come with the patient, we sign you up. So what can we do to help those caregivers? We can educate them. We need to do this with some consistency of message, just like we do for patients, hopefully saying the same things over time in each setting where the patient's involved. We need to assess the caregiver as much as the patient. You all know the people that come and they're exhausted. They are simply exhausted. And like Paige said, they're ready to strangle somebody. We had a conversation last night. They start to say, what about me? And that's a very valid concern. Looking at what are the resources available within your setting, in your community, nationally and internationally, that are available to caregivers. And there's a very nice list in the paper, in the St. John supplement, with links to websites and such. This is also, as Joseph said, we need to bring all these disciplines together and really, and Paige as well, really take advantage of our social workers, nutrition therapists, counselors, and such, and support groups can play a very major role. So back to Indira, she's 14 months on maintenance, starting to have a little creeping up of that IgG kappa disease. Again, 3 sequential visits. So one number does not make a trend. You got to follow things over time. She's also developing secondary or progressive anemia, so we need to keep that in mind. We're going to repeat a more extensive workup, including a bone marrow. So we don't do bone marrows all the time, but if there is a worrisome trend, we want to find out if something's changing. And in this case, indeed it is. She's developed another cytogenetic abnormality, also unfavorable. So as that trajectory, if you recall, it's clonal evolution, shorter duration of response, and we're now having this other clone that is becoming predominant. Similarly, we find some upticking in the myeloma indices here, and we now continue to have a problem with kidney function.
And unfortunately for Indira, she was on 2 of our best drugs. She's relapsing on bortezomib and lenalidomide. So those are 2 of our best drugs. We have 2 newer drugs that are equally good in certain situations, but based on their FDA approval was partially based on some of the research that Dr. Kumar presented, that patients who are relapsing on those 2 great drugs have a particularly poor prognosis is conferred because there just isn't much left there, especially with Indira relapsing. Now, the good thing is that we had that prior research. We talked about bortezomib can resuscitate the kidney function, and it can help aid kidney recovery, but unfortunately, she's on it. And so now what do we do now? So, Sandy, what would you do for her?
Well, what we decided to do was look at one of the newer drugs that's approved in the relapse refractory setting. And even though she's had some of the drugs in these classes, what's important about the newer compounds is that they can work in those people that already progressed on a similar class of drug, but not the identical compound. So in her case, we've chosen pomalidomide and dex. And we are going to continue with the pomidronate therapy. Very important to now set expectations. This is a shift for her in terms of being on an oral therapy only. So being very clear about how to take the drug, 4 milligrams once daily, days 1 through 28 of a 28-day cycle, without food. And we need to be very clear on what without food means. This may be changing with more recent data, but it's important to understand how drugs are given and what that means to a patient and how they can incorporate it into their daily routine. So pomalidomide, or Pomalyst, as you see, is approved in relapsed refractory multiple myeloma fairly recently, basically just over a year ago. It is an oral compound, and as with many oral compounds, we worry about the CYP450 pathway, so we have to consider that. And it is an immunomodulatory agent, or IMiD, and so very similar to thalidomide and lenalidomide, requires a safety program, or REMS program, for prescribing. So we get to have all those great safe sex talks with older people, and usually we hear way more than we ever wanted to know, right? And people are blushing, and they're like, you know, what? You want to have sex? I'm like, no, no, no. No.
Not today.
Right? Tell me, right? You had that conversation, I'm sure, right? So here's the toxicity profile. This is the other thing. As new drugs come out, we need to really say, okay, what are the key things that we need to think about? And these aren't really very different than the rest of what we do in any hematological malignancy, myeloma included. So cytopenias, not unexpected. These are people who've had a lot of therapy, so they may be a little bit more prone to that over time. We just need to know what the safety net is. As with the other IMiDs, DVT prophylaxis is recommended, and so there are very clear parameters available. You can find them on the IMF website, on the ASH website, in publications. Low-dose aspirin, 81 milligrams for the lower-risk patients, full anticoagulation for the high-risk patients. Also infection and pneumonia, you can see here, are the leading cause of death in multiple myeloma patients. So we do need to be very vigilant on prophylaxis for infection if that's necessary, but also reportable signs and symptoms for the patients. And then really, again, going over the REMS program here. So for Indira, our key here for adherence, as we weave this theme through, is the importance of consistent therapy, and you've heard some of that data already. What should she do if she misses a dose? Just very practical educational things for that patient. Really early identification of adverse events. If patients get very sick early in their course of treatment, end up in the ER or whatever it is, miss a key event, they're going to be reluctant to continue on that specific therapy. So if we do our best to really get them identified early and manage those side effects promptly, they're going to want to continue their therapy much better. And then always, always, always continued supportive care. So after 2 cycles, she's in a PR. After 4 cycles, she's in a very good PR. So we're happy about this, and she's continuing on therapy. So we're going to introduce you to our last patient. This is Roberto. Roberto is a retired businessman. He's diagnosed 3 years ago at the age of 66. You can see a pretty significant disease, plasma cells of 70%, again, translocation 414, and he presents with anemia. He's treated with Cybord D for 4 cycles, followed by an auto transplant. So again, very typical scenario. Lenalidomide maintenance is planned for 2 years. He's given zoledronic acid for his bone disease, and unfortunately, at 6 months post-transplant, he starts having a rising serum-free light chain. So a little bit more about Roberto. He's married. He lives 45 minutes from the treatment center, depending on traffic, since we're in LA, right? His wife is 67. They have 5 grown children. All but 1 live out of town, so they're away from where they live. And he has 10 grandchildren, which I'm assuming they want to spend some time with. So their key factors here, personal and family factors, are transportation and the time with his family. We're going to do the standard relapse workup, so a skeletal survey, bone marrow biopsy aspirate. You can see, again, cytogenetics. His myeloma profile, he has IgA lambda, so the IgA, very large protein, is 3292. M component is 0, and I think that's important to know, that you can have these abnormalities without having the bump initially in the M spike. The other labs you can see, the most concerning here would be, again, an elevated creatinine. Again, the renal issues in myeloma, very, very common. So what do we have? We have relapsed multiple myeloma with renal compromise, and for that reason, we want to use a drug perhaps that's a little bit easier to use in someone with renal compromise, and we choose for him carfilzomib continuous therapy, again with zoledronic acid, for his bone disease. So carfilzomib, again, one of the newer approved agents, is given IV. It's approved in the relapsed refractory setting, and it is something that, although the renal function studies haven't been clearly done, or they're in the process, they don't think there's any abnormality, there is some recommendation for a minor dose reduction to start. So how it's given, it's basically given 2 consecutive days for 3 consecutive weeks, followed by 1 week off. So you're going to do Monday, Tuesday, 3 weeks in a row, take a week off. So days 1, 2, 8, 9, 15, and 16. It is a proteasome inhibitor, so when the trials were designed, we designed them similarly to our other proteasome inhibitor, and so there's some fluids to be given in the early treatment with the drug, also some pre-medication with steroids. In our practice, we tend to get rid of those over time. And then you can see that cycle 1 normally would be 20 milligrams per meter squared, followed by subsequent cycles at 27 milligrams per meter squared, as long as the prior cycles have been well tolerated. Again, side effect profile, very similar to the other treatments for multiple myeloma, so not a lot of surprises here. But what are the nursing implications? Just some very practical things. If you're starting someone on a new drug and you know that there are certain side effects, in this case, this dyspnea that can occur, people feeling like they have a heaviness in the chest, you're going to be very concerned about heart attack, PE, whatnot. So what I do in my practice is I say to patients, you know what, for the first cycle, maybe the second cycle, you can do Monday, Tuesday, Tuesday, Wednesday, maybe Wednesday, Thursday if you're in pretty good shape, but we're not doing Thursday, Friday, and we're not doing Friday, Saturday. We're open on Saturdays, because then I don't have time to have you call me and address these things, and you're going to end up in an ER, and that's never a good thing for anybody. So just practical things, start them earlier in the week, and then they can negotiate, later in the week if they're working and need to have that time. Prophylaxis for shingles, so this again is a proteasome inhibitor. These patients are relapsed refractory, they're immunocompromised. We want to make sure we keep them on acyclovir and really manage that effectively. So back to Roberto. He has a PR after 3 cycles, a very good partial remission after 5 cycles, and we're going to continue him on treatment. This is relapse refractory disease. We're now at this other end of the trajectory where it's just going up, and the time that it's down is shorter and shorter. So this is the paradigm until disease progression or unacceptable toxicity, because we know those malignant clones are just waiting back there to do naughty things. Continue supportive care, and then we're going to negotiate time off to allow him to visit his family.
So it's wonderful that Roberto had received a response from these agents, but what if he didn't? What if Indira didn't respond to pomalidomide? Then she could have gone to another agent, and these clinical trials are obviously, we should always be recommending clinical trials, represent some of the newer drugs that are coming out. And I'm just going to quickly go through the next 4 top agents that I want you to be on your radar. They're not yet FDA approved, but they have very mature clinical trial findings and neat mechanisms of action, and they might be in your clinic soon. So elotuzumab is a humanized monoclonal antibody. So think of rituximab. We know how to give rituximab. It's a monoclonal antibody to CS1, which is a cell surface protein that's highly expressed on myeloma cells, so it specifically targets that. There's some phase 2 and phase 3. Phase 2 results, the ELOQUENT trial is going on in phase 3 development, but basically it's very promising in combination with lenalidomide and dexamethasone. Another IV, which is so exciting too, just like the elotuzumab, another monoclonal antibody to CD38 target is daratumumab. It's small studies, very small 1-2 studies, phase 1-2 studies, but really showing promise by itself, and especially since these drugs all play nice in the playground together, they work better together than by themselves, we think daratumumab will work better in combination. The next 2 drugs are oral proteasome inhibitors. Think your bortezomib, think of carfilzomib, are proteasome inhibitors now in a pill form. So this study, the MLN 9708 study, is a single-arm study with the exacimib twice weekly with Len-Dex. And so the cool thing about this is that we have 64 patients in the study, and they're newly diagnosed, and this is showing really promising results in that it's very well tolerated, and again, it's an all-oral therapy. So think of those people that want to go on the cruises. On their off week, you can go on a Disney Dream Cruise or something if you live on the East Coast, and be back in time to start your next cycle. Oprozumib is another oral proteasome inhibitor, and in this study, about 42 patients, it's like carfilzomib in terms of its efficacy, and it's once daily modified release. So it's oprozumib, and that's an oral pill. So Sandy?
So our key points: relapse or progression is inevitable in the majority of multiple myeloma patients, so that's a very big concern, obviously, for patients. We need to be thinking about the whole disease trajectory, preserving future treatment options by effective management of adverse events, understanding these therapies, minimizing any of those adverse events, and working with the patients and the caregivers to help them understand their disease and really do as well as they can living with multiple myeloma. So with that, I want to thank you for meeting some of our people, Ed, Rebecca, Carl, Indira, and Roberto. And we have a very rich network of support in the International Myeloma Foundation website. So the website is there, the 1-800 number is there. We encourage you to access that. It's not just for patients, but also for caregivers and others. Please do take a minute to complete your evaluation form so that you can get your CEs. So it's this little yellow sheet of paper here. You're going to leave that at the back. And we will be up here to answer questions if you have those. Also, a number of other publications that are good resources for you through the Clinical Journal of Oncology Nursing. And again, these can be accessed and downloaded. Also, these are on your CD-ROM in your packet. On behalf of the International Myeloma Foundation, we thank you for your attendance and participation.
Thank you. Thank you.
Thank you. And we hope you enjoy the rest of Congress. Have a wonderful afternoon.
Thank you.